This video is going to focus on the hip. As in every video, we are going to start with the palpatory anatomy that is functional to the joint mobilization we will see later on. So before starting with the hip, we should probably focus first on the pelvis. I'm showing you the iliac crest line that is very visible. We go there with the hands, and then with the thumbs we just move them internally and we go on the ACES, the anterior superior iliac spine. From here we have a full picture of the pelvis, and from here we can also find the pubis here. By following an oblique line we get to the pubis, so we have a sort of triangle between the iliac crest and the pubis. Going down laterally on the thigh with the index, I'm pointing it, we find a bone protrusion that is the greater trochanter. We can see it very easily if we bend the hip. It's another way to find the great trochanter. Now, using the model, the plastic model, let's see the functional palpatory anatomy right on the model. So we can see the hip and the pelvis. We see first the ACES and then the AIS, anterior inferior iliac spine. The ACES can be touched, whereas the IS cannot. Greater trochanter, and this is the lesser trochanter. Let's start with a joint mobilization of the hip. We know there is a very mobile joint. The big problem of the mobilization of the hip is that we are trying to mobilize a very big joint with a simple grip. So in this case, let me show you the mobilization of the hip using our body. So we grab the lower limb of the patient, we place it in between our legs so that we can hold it and our hands are free, always with a bracelet grip. As you can see, my hands are like this, so lateral and medial bracelet grip. We grab with our hands, one in the internal part, one on the external part of the thigh, and we grab the femur. I am helping myself with the elbow because it's such a big joint and I can't mobilize it just with my hands. I'm performing a decubitation here. Let's say that it's a sort of abduction, adduction movements of the head of the femur. Since it's a quite a difficult technique, I suggest you get the right position. We need to lean forward with a low center of gravity. Remember that my medial hand, which is my left hand now, by hugging all the abductors, might cause some pain if our abductors are a little tense, so we always need to ask a feedback to our patient. So in this case, we only change the position of our patient, is lateral recumbency, and we're going to do a mobilization that is exactly the same as before, which is a total mobilization of the hip. Is exactly the same, but in this case we have a great benefit because we not only have a more comfortable grip, but we can make a movement that is somehow underrated nowadays by all the rehabilitators. Also, I'm one of them. The extension of the hip is fundamental, especially in the step. If you think about when we take a step, we make exactly this movement, and in the lateral recumbency it's very comfortable to make this movement. So what's the position of our hands now? We hug the leg of the patient, we hold it with one arm so that my left hand is free, and I'm going to place the left hand on the iliac crest, blocking the femur, that is the other bone. Why is it fundamental to block with my proximal hand the femur, while the other hand does flexo-extension, abduction, adduction, and the circular movements? We have the freedom of doing any kind of movement, but it is important to block the iliac crest because if we don't pay attention and we don't block the iliac crest, then all the movements will go on the lumbar part of the spine, and that wouldn't be very helpful. Plus, it wouldn't be a mobilization of the hip. Instead, by doing this, by blocking the iliac crest with my left hand, I will do a joint mobilization, a total joint mobilization. I have to say that I use a lot this technique on people suffering from LBP, low back pain, because by releasing the hip, we somehow reduce the pressure and the load on the hip.